So what are we going to talk about today? Well, obviously there's a lot that's new in MS every year, so this is always a fun talk to update. But we are going to try and go through the basic signs and symptoms and how to diagnose MS in your clinic. I know that most of you have to see all sorts of types of patients in the community, and MS can be a bit of a conundrum for anybody, including someone who's an MS expert. So I just want to try and make it really easy for you to recognize it and know when you should order everything to consider the diagnosis and how to go through it. So we're going to go through the diagnostic criteria, a few of the mimics, and then the basics on the disease-modifying therapies. Obviously, each of those could have its own talk. There's so many different choices. So I'm going to narrow it down and kind of give you some ideas on when you would want to start some of our less aggressive therapies and when you would want to use some of our more aggressive therapies. And then we're going to talk about special MS populations and go through a patient case and some questions at the end. So this is a slide that actually Dr. Avidan gave to me. It's kind of a nice infographic that goes through the natural progression of the disease of MS. I like to think of this slide as going and starting from the bottom, basically, which talks about the diagnosis and treatment part first. So in the past, we used to just have a slide that showed MS with a lot of different relapses and then eventually getting some disability towards the end. But as we know, it really starts a long time before we even see it. So there's a radiographically isolated syndrome, that's the RIS down here at the bottom, and then we have the clinically isolated syndrome. And those may or may not develop into true MS. They may or may not continue. It might be a one-time thing, or they may develop into MS. We actually don't have a lot of good guidelines for how to follow those folks other than with watchful waiting for the RIS folks, for the ones that you just see, spots on the MRI and you think, okay, this person was in a car accident, what do we do about that? So we're not going to talk about that today other than to say that you should keep an eye on them. And then for the clinically isolated syndrome folks, we'll talk about how you can diagnose whether or not they have MS and go on to treat them. The relapsing forms, obviously, we know the most about. That's going to be the bulk of your patients. That's going to be about 85 to 90% of your MS patients. And those, of course, have a lot of different therapy treatments. And then that tends to transform about 50% of the time into the secondary progressive MS. And we have a little overlap here, as you can see. This didn't used to be on this chart, but here you can see there's people that are still having relapses, but they're starting to go in the secondary phase. We'll talk about what that physically looks like in your clinic. And then they go into a non-relapsing phase where it's really just a degenerative phase with no real inflammation anymore. Unfortunately, there's no therapies that are targeted for this particular disorder as of yet. The new medications that we'll talk about are for this active part of the secondary progressive MS. But, obviously there's a lot of things that are still in development. How does this look like in the clinic? Well, obviously you see a lot of these relapses. Sometimes the patients recover. You see that on this disability sort of angle here, they're getting better, but they're left with a lot of residual disability. So this is kind of a person who has transverse myelitis, but unfortunately they're left with a foot drop. And as you can see with each relapse, they tend to get more and more disability until they finally transform into the more progressive phase, where they start to get progression even though they're not having a relapse. So in between the relapses, they'll start to slowly have difficulty with walking. And you see this person progressing to a walker and then a wheelchair and then they're bedbound. And so that's sort of the natural history of about 50% of the patients that go through this other phase. During this time, you see that there's a lot of lesions in the beginning on your MRI scan. Some of them are going to be enhancing them and some of them are not. But then over here in the progressive phase, they tend not to really get any new lesions on their MRI despite the progression in their disease. And you can see that the reserve overall declines and they get a lot of brain atrophy, especially towards the end in the progressive form.